Please welcome back to the stage, Cokie Roberts.
So I suspect that HHS will, when he said, bring us your ideas, you're on. Our first panel is patient advocates, and we have a great group of very knowledgeable people about Part D, but also who are very involved today in making sure that people that they represent are able to have access to the drugs they need. So please welcome our panel. We have Leslie Freed, the Senior Director of the Center for Benefits Access at the National Council on Aging, Carl Schmid, Deputy Executive Director of the AIDS Institute, Andrew Sperling, Director of Legislative and Policy Advocacy for the National Alliance on Mental Illness, and Pam Traxel, Senior Vice President, Alliance Development and Philanthropy, American Cancer Society, Cancer Action Network. So please welcome our panel. Hello.
Hello.
Hello. Welcome, all of you. So, Leslie, I wanted to start with you because we were talking backstage about sort of horror stories of the beginnings. So we've got all this good news and how well the program really is working, but 'twas not always something that you could project in that way.
Right, thank you very much. When, for about the year before the Medicare drug benefit was going live, so January 2006, many of us would meet with Dr. Mark McClellan, who was the administrator, and Dr. Jeff Kelman. We were expressing concern because there was a large population, the Medicaid population, who were also on Medicare, who were transitioning from Medicaid and open formularies to Medicare Part D, which had formularies and preferred providers, and we were very concerned what would happen on January 1st, January 2nd.
And we're talking about millions of people.
Millions, 6-7 million people. And we were reassured that there would be seamless transition. That seemed to be the words of the day. And come early January, it was pretty chaotic. There were very long lines at pharmacies. People couldn't get their drugs because they were auto-enrolled into plans that may not have covered their drugs. And, but to the credit of Dr. McClellan and to Dr. Jeff Kelman, we had almost daily conference calls with them. They were very concerned. They were aware that the beneficiary advocacy community were getting calls of, I can't get my drugs, there are long lines at the pharmacy, and real chaos. But they were holding regular calls. Dr. Kelman actually said, email us, let us know what plans there are problems with, what state, what pharmacy, and they were working through these problems the first few months of the program till things sort of calmed down. But it was a very scary time because these are low-income people who couldn't pay out of pocket to get their drugs, and yet their lives really depended on it.
But even for people who were not transitioning from Medicaid, it was confusing. I remember walking through the whole process with elderly mother and mother-in-law, and figuring out what to do, what to sign up with, all of that. So, how did you deal with that for your communities? Do you want to take that?
Sure. Education was really important. And so we all worked together at MapRx and with the HHS to provide information. Actually, there was a discount card that was used as a transition. And so there was a lot of education to be done then. And but there was a lot of controversy. One thing, you had to make sure, as you mentioned, Leslie, that you're on your right drugs, and that's really important. And so they had to choose a plan that had their drugs. And then the other thing is,
which wasn't easy to figure out.
Right, and there was a plan finder, and so you would go through and you would say, oh, I'm on these 6 drugs, and plug that in, and this is the best plan for you. But then, one thing is have access to your drugs. The second thing is, could you afford it? And that was the other big controversial thing. I think everyone knows about the donut hole, the famous donut hole. And so that was a concern too, that you're responsible for a certain amount and the plan as well, but then you have to pay everything. And that was an important concern for people as well. And could they afford it?
And that remains a concern, right? I mean, the out-of-pocket costs getting higher, as we just heard. So where do we go with that, Andrew?
So we face a coming cliff because the Affordable Care Act actually filled the donut hole gradually over time, and that's worked out pretty well. But because the second part of the Affordable Care Act was done through a process called budget reconciliation, which I could bore everyone for another hour explaining what budget reconciliation means.
I've had to do it on the air over.
But the Affordable Care Act was passed in 2010, and there's a 10-year budget window. So at the end of that 10-year budget window, we're going to adjust the measurement of that cap, and people could face as high as $1,500 in extra out-of-pocket cost in 2020 when that budget reconciliation window expires. So Congress needs to act on that to protect beneficiaries.
And Pam, that's just one of the things that you all are concerned about, right?
Oh, yeah.
So talk about some of the challenges.
Well,
that we have, right?
I think that one of the challenges that we face is really how patients deal with that out-of-pocket cost. For cancer patients in particular, they face really high costs for out-of-pocket. If you are a CML cancer patient, you can have out-of-pocket chronic myeloid leukemia. You can face an out-of-pocket cost of about $6,300, which is very unaffordable to most Americans. And fortunately, this is a cancer that has become more of a chronic disease, so you'll face that over multiple years. So one of the things that we've been advocating for is to cap out-of-pocket costs in Part D so that patients can have a better idea of what they can expect to plan for in terms of their cost. I think one of the biggest challenges that cancer patients face is that in addition to battling a life-threatening disease, they really have absolutely no idea what their medical costs will be.
And they keep changing. I mean, thankfully, as research creates new treatments, then they become very expensive.
Well, and that's also why the protected classes are so critically important to all of us here and all of us in this room. For a cancer patient, protected classes means that a new therapy is instantly available to a Medicare beneficiary, and that might be someone who needs that therapy literally the day after it's approved, right?
Right. And
so
Carl,
I want to step back and define what that is for the audience.
Right.
So the way the law is written, a plan has to cover only 2 drugs per class. That just doesn't work. And for a lot of conditions, particularly, we represent people with HIV and hepatitis, and HIV is one of the protected classes. First of all, we have combination therapy. You take drugs from different classes to produce one drug. And it's really important that the patient receives the drug that the provider prescribes. Not every drug is the same. Not every person living with HIV or any other condition is the same. With HIV, you have to do resistance testing, and you have to see and if you're on the wrong drug, you build up resistance to every single drug in that class, which affects you for the rest of your life. So it's really, and people have other complications too. They just don't live with HIV, cancer, mental illness. They have other comorbidities as well. So not every drug works the same way with someone. Some people have side effects. And so that's why, we all advocate for, that every drug in these classes need to be on the formularies so the patient gets the right drug.
And Leslie, each of these folks represents a specific disease, but you're dealing with the older population as a whole. And so do you see these problems something that you look at your population and say, they need everything?
Right, so at the National Council on Aging, we do a lot of work with Medicare beneficiaries, especially those who are vulnerable. And we do a lot of work with the state health insurance assistance programs, which are SHIPs, that counsel Medicare beneficiaries. So we often hear from Medicare beneficiaries as well as from SHIPs that they are in a plan and the drug that they are taking, and they might be taking 7 or 8 drugs, are not covering certain drugs that they are prescribed. And while they may or may not be on a protected class, as was just noted, if your drug plan is only covering 2 drugs per class and your drug is not on the formulary, then you either have to file what's called an exceptions, which is an important protection, or go without or pay out of pocket. And for, just as a level set, Medicare beneficiaries, about 50% have incomes at or below about $25,000 a year. So they are a low, they're on fixed incomes, they have low incomes. So we're very concerned about making sure they're on the right plan. And just to say, every year, back to education, every year, the plans change, the formulary changes. So people need to shop, or should shop, every single year because those plans change. But the Medicare Plan Finder tool, which was referenced, isn't doing the best job
of keeping up.
And so, in fact, NCOA just released a report with Clear Choices campaign on ways to improve the Medicare Plan Finder tool, because it's the only tool to really shop for the Medicare Plan Finder, for the Medicare plans.
And I mean, we rejoice so much at all of the advances in medicine, but keeping up with it in terms of getting people access to the right drugs can become very, very difficult then. Right?
Yeah, but remember, this is a competitive program, and I think that's what has worked as part of it. Let's step back. If we would have had essentially followed the model of the fee-for-service Medicare program and had a single government program with everyone with the identical coverage and a single national formula for the whole country, where we would be. We wouldn't be able to keep pace with the advances in development of new therapies. And Part D has really done a good job of keeping pace with the advances in science and the advances in development of new medications.
And the competition, you find that it is effective? I mean, because that's what we were hearing just now from HHS. Right?
Yeah, it's certainly helped, but premiums have been stable. And actually, in some parts of the country, have actually gone down from year to year. So the program has been very successful in keeping premiums affordable. There's some other areas where it hasn't kept pace, like the out-of-pocket cost.
Right, yeah. So just to jump in to respond to that, I think that looking at just the premiums is dangerous, because we can look at, am I still on? We can look at the premiums, and they may be all low. However, the out-of-pocket costs, the co-insurance, if you have a drug and you have to pay 50%, it could be 50% of a lot, and therefore is unaffordable. So we encourage people, they really have to shop, not just look at the premium, really look at the out-of-pocket costs for your drugs.
And your previous panel talked about rebates. And that's a real, it's a very complicated issue, but we see that in with the Medicare system. Because
what you want is a rebate at the place when you buy the drug.
Yeah. So there may be a high-priced drug, and the plan doesn't pay that amount. They have a negotiated rate, and they get this huge rebate. We've seen this particularly with hepatitis C, where there's a lot of competition and some high rebates. And unfortunately, that's not passed on to the patient, and they have to pay the list price of the drug. And so we would like to see those.
And is that a regulatory issue or a legislative issue?
That's a good question. I think that there's some question if they can do it without legislation or not.
Yeah, certainly this administration is taking an aggressive position that this is a regulatory issue, and the blueprint on drug pricing is taking some aggressive positions on things that the administration would like to do relative to rebates. And Secretary Azar has actually said he'd like to get to a system where we do away with rebates entirely.
Pam, this question of out-of-pocket costs must be particularly worrisome for cancer patients? I mean, the prices of those drugs are just phenomenal.
The prices are phenomenal, but the success we're having with a lot of these new therapies is amazing. And so I think that, you know, for my organization, the goal is obviously being diagnosed with cancer is the worst day of your life. But helping a patient go through that journey is really important to us. And right now, when you and everyone in this audience knows someone who's been impacted by this disease, when you talk with them about their journey, one of the biggest questions they're going to have is, how much money is this going to cost me? Right? And to Carl's point, our patients don't just have cancer, they have 4 or 5 other diseases that they're trying to treat with drugs. And so trying to figure out a way to make those costs more predictable while also guaranteeing patients access to innovative therapies is a real challenge. But cancer affects 1.7 million Americans this year are going to be diagnosed with cancer, so it's definitely something we as a nation need to work together to try and solve.
And do things like the moonshot make a difference, or is that something for the future and we need to deal with the present?
I think the most important part of the moonshot is the call by Vice President Biden for the cancer community to work together to make more progress in 5 years than we could in 10. And I think during the moonshot, there was a lot of conversations among diverse stakeholders to work together. I actually think that we should use that same collaborative spirit in working on the issue of drug pricing and making sure that Medicare Part D continues to be a successful program. We can't all sit in our silos and fight for our positioning. We have to do what's best for patients, keeping in mind that all of us at one time will be patients.
Right.
Yes.
If not now.
Yes.
And do you, Leslie, again, since you're in the sort of overview position, do you see that happening?
So it's interesting you say that. I know at NCOA we have a Improving Medicare Markets initiatives, because in order for Medicare Part D to work, the market has to work. And we work with some pharmaceutical companies and some health plans and beneficiary advocates, but on some basic level, information, notices. But a lot of times we have very different reference points, let's say. And so I think it's really hard. But there are certain things we can work on together. The low-income subsidy, the Extra Help, which is a program that provides both premium and cost-sharing assistance to low-income people. And I think we can all agree that that program needs to be improved. There's an asset test, which is way too low, so many people who are low-income, even at 100% of poverty, but if they have $20,000 in a nest egg that's supposed to last the rest of their lives, they're ineligible. So I think there are certain pieces, probably not drug pricing, but there are other parts of the programs that I think we really can work together to really improve the program.
I think we work very well together, and I think that's what MapRx, is a testament to. It's been around almost as long as the Medicare law, and it doesn't matter what condition you have. It doesn't matter if you're a senior citizen or not, or
Are you looking at me?
or through low income and disability. We all are patients, as you said, at one time or another. We all need access to medications, the right medications, at a cost we can afford. So we do work together. We have a common agenda, and I think it's power in numbers.
Well, which is, of course, what this is all about today. And in bringing everyone together, as I said earlier, MapRx has commissioned this study, which came out earlier this week. And Andrew, I'm just wondering, was there anything in that report that you found particularly striking or that we should be emphasizing?
Certainly the findings about how popular the program is with beneficiaries, that's encouraging. We've actually known that for a while. And the access issue. And it really is working to protect access, and the cornerstone to that is this 6 protected classes policy to make sure that people with serious chronic conditions such as epilepsy, cancer, schizophrenia are getting access to the medications. We know that policy is working, and we have some concerns that the current administration wants to tweak it, and we want to make sure that these protections stay in place.
That they tweak in the right direction.
Exactly. Because the previous administration actually in 2014 issued a rule that was never finalized that would have taken away the protections for antidepressants, immunosuppressants, and then a year later, antipsychotics. So,
Why?
well, again, I think the plans had been making the case to, as far back as the Bush administration, that this policy for six protected classes was preventing them from being able to negotiate rebates and discounts for drugs within those six therapeutic classes. And that's simply not the case. While they do have to put it on the formulary, they have a whole panoply of tools available to them to negotiate with manufacturers. They can place it on the 4th tier. They can have 20 or 30% co-insurance. There are all kinds of ways in which they can use incentives and levers to negotiate discounts within these 6 therapeutic classes. So we believe the policy is working to protect access, yet still allowing plans to negotiate rebates and discounts from manufacturers.
But you were saying earlier that there was one school of thought that said get rid of rebates altogether.
Yeah, and again, that's has been mentioned by Secretary Azar a number of times in association with the Trump administration's blueprint. We're not exactly sure how that would work. We know that there are issues around transparency. We know that that when there's a high price for a medication and there's a high rebate, that creates incentives, not necessarily for actually to lower the list price, because you have a high list price and then a rebate that's based on that high list price, where the PBM is generating significant revenue through that rebate. That creates problems around transparency, because the list price really becomes a fiction, because that's not what's actually played in the marketplace. So yes, there are some issues around transparency with rebates, but right now it's a tool that the private sector has both within Medicare Part D, and these same PBMs are negotiating on behalf of employers and health plans to ensure that we're actually holding down costs. It's funny. So actually, prescription drugs is actually probably the most transparent part of the healthcare system. Because we know that here in Washington, D.C., there are vast differences between what's paid for a hospital bed here in Fairfax County versus Prince George's County versus the district. So it's not exactly we have,
or even for different surgeries.
Yeah.
The same surgery can have different prices.
So actually, prescription drug medications is one of the most transparent parts of our healthcare system in terms of pricing. It's just that we can always do better to try and get the right incentives to ensure access, but yet ensure that coverage remains affordable.
Well, I'd like to push back just a little bit, because we may know the price of a drug at a certain point in time.
Yes.
But we know that people shop. In fact, open enrollment is just around the corner, and they may shop for a new plan in November 1st and make a decision based on the out-of-pocket costs for the 6 drugs they're taking on November 1st. But that price can change. So come April 1st, it may be a sad April Fool's joke that the price of that drug has gone up because it's not fixed. And if someone is paying a co-insurance payment, then their out-of-pocket costs are increasing. And so that affordable plan as of November 1st may be much more expensive and unaffordable on April 1st. So that is a huge problem. We hear about it a lot.
I would also say that there's an issue with that same patient who does the research, which most seniors don't, to look at their plan, to think about re-enrolling, to look up the drugs that they're taking now, and then they're in their plan year and they get diagnosed with cancer, and then they're not ready. And so I think that one of the challenges we have around transparency is, while I agree with Andrew that there is a lot of transparency around drug pricing, we have a long way to go around patient ability to understand those costs, right? And I think that's
I want to be clear
a challenge.
What I meant by transparency. There is some transparency, but in terms of what a patient or a beneficiary knows what they're going to pay at the pharmacy counter, that's not always transparent, particularly when you're dealing with co-insurance, because it's a % of a price that you know nothing about.
Right.
And Andrew, that's exactly what I was going to say. That most of our drugs are on high specialty tiers, and people, first of all, you know, people shop mostly on premiums. And for Medicare Part D, they're pretty good, thanks to, you know, the rebates, and they're able to lower the price of the premiums. But if you're facing co-insurance, which, you know, could be up to 50% for our drugs, that's an awful lot of money.
And explain co-insurance.
Yeah, so instead of a copay, which most people are accustomed to, $50, $100, a lot of drugs these days, particularly in our areas, are co-insurance. It's a percent of the list price. So say a drug is $3,000 a month, which is about the average for HIV, the patient is paying $1,500 if it's a month. And that's in addition to premiums. And so they would have to pay that when they're in the donut hole. And after they reach the catastrophic limit, they're stuck with 5%. First of all, they get through the donut hole like in January or February because they eat up that cost very quickly. And then they get to the government pays, and then there's 5% that the patient has to pay there's no maximum out of pocket. And that could be, 5% may not sound a lot, but it could add up for cancer drugs, for HIV drugs, for hepatitis drugs. And I think that's one thing that, I would like to emphasize in the MapRx report is the need to have limits on the out-of-pocket maximum for the patient, because it's just a lot of money. And, access to medications is just so important to stay alive for people, and a lot of people can't afford it. Final point, the administration is working hard to address drug pricing, but the blueprint, the title of that document is not only lowering drug prices, but lowering patient cost sharing. And I think we all agree that we would like them to focus on that a little more, particularly in the Medicare Part D spot. And I think the point that Andrew raised about the impending cliff, over $1,000, and if Congress doesn't act soon, and just the maximum out of pocket, looking at specialty tiers as well, would all be really helpful to lowering the cost for patients.
Well, I noticed in the report, and this gets to your point about how fast people go through the donut hole, 61% of the cost of Part D is for catastrophic, so post-donut hole, right?
Yes.
So which speaks to the cost of these drugs. I mean, that really is what it says. Do your organizations have means of helping those patients who are unable to meet those costs?
So we actually work with a number of charitable foundations to help patients with those costs. I think the challenge is, Koki, there's not nearly enough support, and patients do not know that these programs are available to them. I deal with people all the time who, I say, well, have you talked to a copay foundation? What's a copay foundation? Say, okay, let's connect you up. So I think that there isn't as much of a safety net.
And give me an example of what a copay foundation would be.
So a copay foundation would be like the Patient Advocate Foundation. They actually do an amazing job of helping patients be able to access either their own funds that they have as an organization or an industry-sponsored fund, depending on their insurance, to provide them the support they need to get access to their drugs. And I think that the problem that we don't understand is that most Americans can't afford a $400 out-of-pocket emergency expense.
Right.
Federal Reserve number, okay, so federal government this year, $400. For the average patient, if we're talking about a specialty tier drug where we're in coinsurance, even at 5%, $400 is
a lot of money.
I mean, people can't do this. And I think that the other challenge that we have, and I find it particularly ironic, that after the holidays in December, when everyone has those credit card bills, we all know what it's like in January when you open that credit card statement and you go, ooh, wow. That's at the same point that many of our patients have to go back through this process, right, to get to the donut hole again. And so to me, it's particularly unfair that in January and February, when people are paying off credit card bills from the holidays, they are going back through this process and they have to afford a lot of money out of pocket. I mean, the bottom line is we need to continue to figure out a way for a governmental solution to this, because there's not enough charitable support to make this work.
So I just want to make one point of clarification, is that the donut hole is actually closing.
Yes.
So in fact, for brand drugs, it closes January 1st, and for generics, for the whole program, it will be 2020. That being said, people still cannot afford these high-cost drugs. And my concern is that with some of the administration proposals that we may see is that there may be more barriers to access to care, and instead of really thinking about the actual drug pricing. Well, we hear that they may, instead of having 2 drugs per class, only require 1 drug per class. We have heard about, we're concerned about the protected classes, whether they will still exist, whether they will put more, give more flexibility to plans, which seems to be the code word, plan flexibility, what that means about access to protected classes. We also know that some plans have what's called preferred networks, and so they have a lower cost, but it may be very far from where an individual lives, and there's transportation issues. So we are very concerned about some of the plan flexibility and the impact it will have on access to someone getting their drugs, when they need them.
I know this is a very educated audience, but I didn't know about the protected classes until this morning. So Carl, why don't you go through?
Well, you learn something new every day,
which is a good thing.
And I think we did a good job talking about the 6 protected classes. But one thing I would like to
tell us what they are.
Sorry. So it's antiretrovirals, antidepressants, antipsychotics, and anticonvulsants, and
plastics.
And immunosuppressants.
Yeah, immunosuppressants. But, I was going to talk about the success of the program.
Right.
We're talking about all these problems, and because we want to make it better. And the 6 protected classes and access to the drugs is really important. But I just wanted to, before we get off the stage, is to talk about how beneficial this program has been. And, for people living with HIV, who need access to drugs every single day for the rest of their lives, this is, access to the right medications, as I said earlier, is critical. And so now people are living with HIV and aging into Medicare. Sure. So today's actually HIV and Aging Awareness Day, and I had to get that in because people with HIV are living longer, and thanks to
living healthier.
Yes.
Well, able to go to work, able to live a life.
Right, and a lot of people came in because of the disabled and low income, but now they're aging and they're becoming senior citizens and qualifying for Medicare that way, and it's just remarkable.
Well, so absolutely, you talk about the success. It's not just the success in getting drugs to people, it's success in having people live longer and have healthier lives. And Andrew, you were saying, I think all of you were sort of there at the creation in one way or another, right? Yep. And you talk about it like it was 9/11 or something, where you were standing.
Well, and I think part of that was because not so much the Senate, but the way in which it passed the House. And I think some of the former congressional staff may talk about this a little later, and the president might even. It was the dramatic 2-hour and 58-minute vote on the House floor, and the president was actually in England, and he was flying back from England, and they were trying to get him on the phone with the last few Republican votes they needed. It was a bipartisan vote, and I hope the staff, former congressional staff, talked a little bit about that. There were, I think, at least close to 24 House Democrats that voted for the bill, and a number of Senate Democrats that voted for the bill. So it was a bipartisan bill. But the most reluctance was actually on the part of many conservative Republicans in the House that didn't want to vote for what for a new entitlement program, and it was a very dramatic 2-hour and 58-minute voat. And
you were in New Orleans,
and I was in New Orleans watching it on C-SPAN.
I said it was fine. 3 in the morning, the whole town was up.
Yeah. I was proud of the fact, I think that many of our organizations actually sent letters of support to Congress. I think that made a real difference. I think AARP was by far the largest. Their endorsement of the bill, I think, was absolutely critical. But there were a large number of patient and disease advocacy and beneficiary organizations that supported the legislation. I think what happened after that, what I found most rewarding, was not getting it over the finish line in Congress, but the work over the next, between November of 2003, December of 2003, when President Bush signed it into law, and January 1 of 2006, all the work that went in to getting beneficiaries educated, the work, the constant meetings we had with CMS about how the program was going to be designed, the work that CMS did at the time, Mark McClellan, Tom Scully, to get the plans to come into this marketplace. This did not exist. They invented an entire new market to get private sector plans to offer drug coverage only to elderly and people with significant disabilities. And there was a real concern about who would want to compete in that market. These are people that have serious conditions and they take a lot of medications. Who's going to want to be an underwriter to come into that market? So it took an enormous amount of work to stand the program up. And there were the bumps in January of 2006. Part of it was because we had this initial cohort of 6 million low-income people that were losing their Medicaid coverage at midnight on December 31st of 2005 and had to turn it on in January 1 over a weekend, mind you. A holiday weekend. So that's what I found most rewarding, was the work in between 2003 and 2006 to get it going, and then going forward to make sure that the
well, we heard
problems were worked out.
A reference from one of the gentlemen from HHS about pharmacy students being involved in that. That was the first I had heard of that. Tell me a little bit about that.
So I think that, and this is a little foggy, but I remember that the pharmacy students were being educated to help people in choosing plans, and I know that happens today. A lot of our SHIP programs actually use pharmacy school students, educate them about how to assist a Medicare beneficiary in choosing a plan, and I think that happened back then because it was so difficult to think, okay, you have to have your list of drugs, what you're the dosing, and where you live and what pharmacy you like to go to, and making choices. So I remember that as well. But I do want to go back to one of the great successes, which is actually there are over 12 million low-income people who have access to, through the subsidy, through the extra help subsidy, to prescription drugs at from $1.35 per prescription to up to $8.35 for a brand drug. That is incredible. So you have this low-income population who probably didn't have access to drugs at all because they're so low income, now have access to drugs. And we know that, as stated in the report, and I think Sandra mentioned earlier, that it has really reduced overall non-drug healthcare costs because people can maintain their treatment regimen, and especially for low-income people.
And Medicaid. I would be remiss if I didn't. People talk. There was actually talk at the time of, well, these Medicaid beneficiaries are, they have coverage now, and they're going to be thrown off a cliff into this new program, this brand new program. In fact, under Medicaid to this day, prescription drugs are an optional benefit for all 50 states in the Medicaid program. And prior to Part D, we had states, I won't name them, some of them
but we know who they are.
Yeah, that to this day, limit beneficiaries to 3 and 5 prescriptions a month.
That's true.
So there were real problems with drug coverage for this population in the Medicaid program, and it vastly improved when these dual eligibles went into Part D.
I think we're agreeing, Andrew.
Pam, you alluded to, but I want to just, before we leave the panel's over, go back to this question of, all right, you're on a plan, and then you get a new diagnosis, cancer. All right, what happens then?
Well, I think you begin a pretty difficult journey where you're working with your doctor to understand what medication you need. You have to learn about Part B and Part D, which is pretty complicated. And then you have to really think about not only where you're going to start your treatment plan, but where you might go after that. I think it's very, very difficult, and cancer patients are really sick. And do you get covered?
Do you get, I mean, if you're in a plan and then you get a new diagnosis, are you covered?
So you will have access to the drugs because oncology products are a protected class. And that's why it's so important that we have protected class status. not just for 1 drug per class or 2 drug per class, but whatever class and whatever drug you need to treat the cancer that you have. And that's why it's critically important. The last thing cancer patients need is to understand that their drugs aren't covered, right? That's the least thing they need to worry about.
Right. So it's say you get a diagnosis outside of these classes. What happens then?
So, it's a very difficult situation. If you get diagnosed with a chronic condition that is not on a protected class, your doctor can look at the formularies. If the drug that's best for you is not on the formulary, there's something called an exceptions. There's actually a very good appeals process where someone can file an exception to their health plan and with support from their doctor say, I need this drug and this is why. And then if successful, then the drug will be covered on the formary.
At what
and that
cost?
is, that's true.
Usually
there can be a
yeah.
cost. There
Yes,
is
usually time.
and then there's another exceptions process called tiering, where if your drug is on a high tier and you can't afford it, you can request that it be brought to a lower tier, again with support from your doctor. And I do want to say that these consumer protections are very important in the Medicare Part D space. And it's unusual because I think in the commercial marketplace, many of these important beneficiary protections do not exist.
So it's another example of success.
Yes.
So with that happy ending note, thank you all very, very much.
Thank you,
It was
Koki.
terrifically interesting. So thank you.
Thank you.
We're going to take